Welcome to Life in Sirens, Behind and on the Scene, a podcast by first responders. We're your hosts, Sophie,
Jamie,
and Aubrey.
The content provided in this podcast is for informational and educational purposes only and should not be considered medical advice. The views and opinions expressed by the hosts and guests are their own and do not necessarily reflect the official policies or positions of any medical institutions, emergency medical services, or healthcare organizations. Patient privacy is a top priority, and all discussions involving real-world emergency situations are de-identified and altered to ensure confidentiality. Always consult with a qualified healthcare professional or your local EMS protocols before making any decisions regarding patient care or medical practices. Listener discretion is advised, as some topics may include discussions of real-world emergency situations.
Welcome to another episode of Life in Sirens. Today we are sitting down for a fireside chat. Unfortunately, we won't have Aubrey with us, but it's me and James, and we're going to talk about Airway. So Airway is one of those things we can really make or break our call. It's humbling, it's messy, and it's never quite like that mannequin in class.
All right. So basics. What is the one thing that everybody swears they're good at, but then you watch everybody do it and it's subpar?
Bagging.
Sure. BVM. I just had a call yesterday where we ended up doing an RSI, but starting out bagging this fella. He was very large, like just like a big dude, and his jaw was really tight, and getting any like leverage to really super seal that mask was very hard. We had a nursing student, and she initially was sealing, and I was like, let's switch.
What a great call for a nursing student.
Yeah. I was like, let's switch, because it was not going well. And then I went to get the seal, and I struggled a lot to get his jaw. Like,
yeah, you just can't, like, he's too, like, meaty back there
Yeah.
behind his
it was
mandible.
hard. It was tough.
Dun, dun,
I
dun.
know. It just made me think. I was like, man, I gotta go practice
Those
this some
are-
more.
I mean, and that's exactly why we're talking about this today, because it is never like the mannequin. I've never had an Airway that's just like, sometimes traumas, because they're usually young, healthy men.
Yeah.
But, like, that's pretty much it.
Honestly. And every time that I get to an Airway that is not just like a run-of-the-mill dude, oh my gosh. Because
Yeah.
even if they are like skinnier with a longer Airway, that's probably going to be a pretty easy tube. They have like a beard.
Yeah.
And then you have
Something
to
is wrong.
seal around that. Something is going on.
Yep.
Yeah. What other like basic tools do you think are underrated?
Well, I think that and I am just as guilty for sure, is like providing Airway adjuncts. OPAs and NPAs.
Me too.
I always forget.
When it's my call, I never remember it.
Yeah.
But like yesterday, I was acting captain, and so I was like, MPA. Does anybody have an MPA? Put the MPA in. Spoiler alert, they already did. But
Dang, you're like, oh, that was my
yeah,
moment
I was
to
like, this
shine.
is my moment. But yeah, I always forget an adjunct until thankfully there's somebody on scene that will say something.
Yeah.
But I never remember it. And ramping
Yeah.
for intubation
Yeah.
is something that
Positioning.
I guess we focused on it in school, but
Yeah, I was gonna say, I think it depends when you came into EMS, when you came
Yeah.
out of paramedic school.
I feel like it was very much just like a slide them up the cot and
Yeah.
there you go. And we really undersold the positioning.
Yeah.
That like ear to sternal notch truly gets you a better view.
And most of our patients are bariatric by definition,
Oh, for sure.
so that's very
Welcome to the South.
useful. Yeah, welcome to the South.
Yeah. Do you remember like when we both really around the time we both first started, you would see medics like slide patients' heads like almost off the
Yeah,
cot
they'd be like falling out. They
and like
literally
hyperextend
would.
them.
Yeah,
Yeah.
that was like a thing. Yeah, ramping, it takes extra time, but we'll get into it. Where like most of managing an Airway is preparing for the Airway.
Absolutely.
So,
Absolutely. Most of the stress that I've seen during an intubation attempt is either poor positioning
yeah.
or being unprepared with suction.
Yeah.
Because then you get in there and you're like, give me the suction. Someone's got to hook it up.
Turn
It's
it
just,
on,
yeah,
yeah.
and turn it on. Or you push the wrong button.
Really quickly, BVM technique. What's the most common? What do we normally see?
Oh, we normally do like the one-handed CE.
Right. And we're moving away from that a little bit, but like I understand we don't always have lots of people, and I get that argument a lot on the internet, but I've worked really rural.
Yeah, you have.
You have someone, I promise.
You can find a human.
There is an SO.
Someone can squeeze that bag
Yeah.
while you get a two-handed
Yeah.
seal. And I understand there are limitations. But we also are in a place now where we have really fantastic adjuncts too.
Yeah.
Between NPAs or like supraglottics.
Yeah, Airway adjuncts and tools and things like that is not cheating.
Yeah.
It's not taking an easy way out. I think there's an ego to it, right? But like, we just got to get the job done with very limited hands. And sometimes that means doing things that maybe you previously were taught that were cop-outs, but they're not.
Yes, and we'll get into a little bit. We'll get into some of the tools and things that you can use that make you far more successful.
Yeah. According to this study of 2022, which all of our show notes will have all these like references and everything, 52% of airway complications are due to poor BBM technique.
Which makes a lot of sense.
That's a huge percentage.
Mm-hmm.
More than half.
And that makes sense. You can't get someone SATs up, so you start your intubation attempt at a SAT of 70, but it's really just because the seal was terrible and they weren't bagging them correctly.
Yeah.
Like, that's rough.
Yeah, that can ruin everything, honestly.
Yeah. That can get you into a code pretty quickly.
And then a study in 2022, which we were talking about adjuncts and how maybe we don't use them as much as we should. Sorry if this is not you and you use an adjunct aggressively, but only 28% of patients received an adjunct before intubation.
Which is also wild.
Yeah.
Mm-hmm.
So.
Because either one, they are just a very easy person to bag. And like, okay, if you're getting great compliance and everything is going well for you, cool. Yeah. That's not very common.
No, not in our setting.
Right? And so I feel like what that leads to is you're starting your intubation attempt already hypoxic.
Yeah.
Which, not our goal.
Not our goal. We have to do a lot of things before we can intubate now, because ideally we shouldn't be intubating someone who's already that far down.
Right? Sometimes you were really just in a bind and you got to do what you got to do. But most of the time, that's not the case. And we do have some options. You have like a nightmare airway. What's the first thing that you grab as far as like your laryngoscope? What do you use?
I used to grab direct because I thought that was the only cool guy way to do it. And now I pretty much exclusively use video.
For sure.
I'll grab both.
Yeah. How do you keep yourself proficient at direct? So you have successful pass rates. In the event that your video, it gets foggy or there's too much goo in the airway and it gets on the screen or it's dead.
Yeah. Right.
How do you keep yourself proficient in direct?
This is like going to be a controversial answer because some people are like so hell-bent on the fact that you should use the best thing every single time, which means video every single time, which again, how the heck are you going to be proficient in that? I really like in those patients, which on my side of things now for my job, we tend to intubate more traumas than medical. So like you have a healthy adult with a head injury, an isolated head injury, and they need an RSI. That seems like a good candidate for me. No other trauma, isolated head injury, young person, fit. I'm going to use direct here because I know that it's going to be a more ideal airway than I might be seeing on a typical basis. So.
For sure. And I think that is a great compromise. That's a great in-between, because whether we want to talk about it or not, is that the tools are fantastic and I think they should be utilized, but you have to make sure that your most basic skills are still proficient.
Yeah.
And I think that's some people's argument. They use it kind of in the inverse where they're like, oh, always go direct. And then, if you can't get it, use video.
Yeah.
And I feel like there are certain airways where that's just not appropriate.
No.
Like there are those hugely traumatic airways, like spinal cord injuries, things like that. Like the least manipulation, the better. And I think video is absolutely your answer there. But I like that if it is an airway that you almost like would deem safer than going direct, I think is absolutely an option.
Yeah, I think I don't know. It really depends, like, the culture of the area that you work in. But, like, in flight, it's absolutely heavy video only. But when I work on ground, it's like, oh, you're using the video?
Yeah.
So it's kind of like an opposite mentality. But I do think there is absolutely a place for direct, and you need to use it because I think Aubrey, it was you and Aubrey, had an airway where, like, the type of video laryngoscopes and the blades that we have were just not going to work for this patient, and it absolutely was necessary to go direct. So, like, that is the reality of the situation.
Yeah.
And it's kind of upsetting too, because there's a lot of providers in flight who never intubated until they got to flight, and they only have ever used video.
Yeah.
And that's like, that sucks, because what happens?
Because in things, we've had an airway where it was too viscous to use video. It kept fogging. There kept being fluid on the camera. Our suction couldn't really keep up. It just was not going well. And so then we went direct, and this airway just ended up being very floppy. Like, epiglottis was floppy. There was lots of floppy tissue around it. Like, it was just hard to manipulate. And so I actually ended up using a Miller.
Yeah. It's a wild transition.
And went in with a Miller and was able to lift everything correctly and get this airway, and it ended up going smoothly. But when you look at your experience level and, like, have you ever had to troubleshoot an airway with other tools?
Yeah.
I have not had to very often. And so I can't imagine never having done it and then being faced with an airway.
Yeah.
That is that difficult.
To me, it's like being handed 12 leads and always going off the interpretation that the monitor gives you, and then all of a sudden you have to do it yourself.
And, like, we all have those supervisors that have been doing this for longer than we've been alive, that, like, for them, it actually would probably make far less sense to use video.
Yeah, sometimes you just need to use what you're most
proficient. We have a supervisor that uses a Miller 4 constantly, and I've never seen her miss. And it would be less proficient of her. It would be not in the patient's best interest to move to video because she is so proficient with a Miller 4. Yeah. You know, and I think that you have to look at your own skill set too. Yeah. I am far more successful with the video, but I want to make sure I'm still proficient direct.
I think it also depends on, like, your scope, right? So, like, as, like, a critical care paramedic, we do RSIs and things like that, and it's, like, so ingrained, for me at least, like, in your brain, like, you're gonna pull out the video because, like, this is just a high stakes situation, and I have a lot of responsibility riding on my shoulders right now, and it's all me, and that's kind of how I feel about it. I'm gonna pull out all the stops.
100%, because I'm about to take their airway, which means I'm 100% responsible for it.
Absolutely.
Yeah.
If I'm not RSIing, those are kind of the situations too where I may use DL.
Yeah, for sure. For sure. It's a very interesting choice to make, but I think it's important that you make a choice. Yeah. That it's not just one or the other all the time, that you use, like, you know, some informed decision making.
Yeah.
To make a good choice. And train.
Yeah.
Use an airway mannequin. Get a difficult airway mannequin. Shoot some blood through that airway. Like, do what you can to make sure that you're prepared and that you're constantly repeating that muscle memory. Because even though it may not mimic a real airway, it will mimic some muscle memory. Yeah. And it's important to rep that.
And I think that's the most important part of it is, like we've talked about, it's kind of like months of dress rehearsal for one, you know, 30-second solo. That's how it is. Like, that's what we're doing in the truck. We're getting everything possibly ready, and that's when the repetition comes in. We're getting everything set up. We're making sure our patient is being ventilated and oxygenated well. We make sure that everybody knows the plan. It's just all together, and then we do the thing, and it's just calm is better.
What other assistive devices do you use?
Oh, you know, a bougie.
Mm-hmm.
I love her. I use bougie all the time, every time, and I think Jamie and I talked about this. So at our ground service, we use the AirTrack, and the AirTrack is interesting because it has basically this little, like, rail system where you place your tube in, and it's pretty snug in there. So ideally, so you're not going to really need anything like a bougie or a stylet because it's, like, so rigid. Like,
yeah, the track keeps its trajectory very specific.
Yes.
And then you have to point it, and you have to have, like, the cords in the center of the screen, and then that's where the tube is supposed to go. And in a perfect world, that ideally works very, very well.
Yes. So I've noticed that even with that, I still like to use the bougie because when you have this AirTrack, I don't know what the heck it is. It's a great device. I love the AirTrack.
Yeah, it's quite good.
But despite what the packaging says, those tubes still fit in there very snugly. So pulling the tube out of the track, which is something you have to do to remove the blade, from the patient.
It's like a sideways peel off.
Yeah, which, depending on what's going on, if you're doing CPR, there's like a lot of movement. So I just like will also add a bougie.
Yeah, because sometimes it can feel... Sometimes you really have to put some force into pulling that tube out the side. It does not peel as smoothly as it should.
Like, oh my God.
And it makes me nervous every time. Ideally, you place your tube, you pass your black line, you're in the cords, you look at where you are on the teeth, you inflate your blade or your bulb, bag, listen to lung sounds, end tidal. Good, right? Then you have to peel off the video.
Yeah.
And ideally, once you bag, then you secure and you keep visual until that moment. But when you peel off the video, you lose visual. And that makes me very nervous.
Yeah, it's kind of scary. It's like very like, it's not as smooth as maybe intended.
And there's a fine line between the amount of lube you can use.
Yes.
Because at some point you just can't hold on to it anymore.
No.
It gets too slippery. But that's what Soph started using the bougie with it as essentially just like a
fail-safe.
Yeah, a fail-safe. That way if your tube does dislodge or move or anything, your bougie is still there until you can get everything secured. And I love that. We had a lot of Airways yesterday. Had an RSI and a GSW and like lots of things. But during the RSI, we were talking about it. They're like, do you use the bougie like through the video or like around the video? And I was like, well, Soph uses it with the video, like with the tube. And then we were talking about it later about how you load your tube with your bougie and kind of rest it like on the top of your hand, and it gives you like the same dexterity. And because I was like, I'm trying to get more proficient with it, so I've picked Soph's brain a whole lot about like how she uses it and what she likes and doesn't like and all the things. And I'm trying to figure out my dexterity, like both with the tube loaded and without it loaded.
I think it's different for literally every single person.
Yeah. But that's what we talked about, is kind of like what we like it. And I talked a lot about like the things that you and I have talked about and how you do it and like watching you do it and how smooth that goes. And it was actually really cool. But the bougie has become very, very prominent, I think.
It's only smooth because I've done it every time.
Yeah.
A million times.
It's very smooth.
Yeah, I love a bougie. I think that it's kind of the new stylet. There's people that will come for me for saying that.
They will. They absolutely will.
That's all right.
And again, do what you're the most proficient in. But like, don't ignore science. So if new studies and new things come out that support change in a different direction, give it a shot.
Yeah, there's a study too in 2020, again all these will be in the show notes, that using a bougie increased first attempt pass rates from 81% to 96%.
That is impressive. That's impressive.
That makes me feel away.
That makes me want to do it.
Yeah.
Like, and if you already have a very good success rate, I feel like that will get you pretty over the edge.
I'm sure this is not with like video. I'm sure this is
probably direct.
Yeah.
Remove every confounding variable.
Yeah.
Gosh, what do you think about LMAs?
I really think that...
Or supraglottic.
Yeah, a supraglottic is great. I think there are ones that are more suitable for pre-hospital than others.
I would agree.
I tend to have the feeling, this is completely anecdotal, that anything with gel in it that has to be warmed up to body temperature, appropriate body temperature, is not appropriate for the field. Because there are many times when we have patients who are too hot or too cold and are not at ideal body temperature.
Right.
That's just how I feel.
Yeah. And I also feel like we have a lot of movement.
Yes.
And so a lot of times this comes down to your kind of patient, the environment you're in, and your level of proficiency with the device. So there's lots of confounding variables for sure. But we just have so much movement. A lot of the times you're not just in a truck. A lot of times you're out, you're still in the field, you have to get to your unit. Like, there's lots of moving this patient, and the chance of that device becoming unsecured or causing any kind of airway damage, I just feel like it's there.
Yeah.
And it makes me nervous. And most of the things that I've read just say like it really comes down to aggressive securing.
Yes.
Like, you have to secure it very, very well.
Make sure you have the right equipment.
I will say that there are plenty of studies. Now, a lot of these studies are not solely pre-hospital. A lot of them are both like pre-hospital and in the ED, because it's just pre-hospital is hard to study. But this is that the iGel specifically, so not just any adjunct, but specifically the iGel, there's a 92% first attempt success.
And pretty solid.
Yeah, and that was in 2021. So as far as like an adjunct and getting like solid end titles and ventilating well, I mean, it has data supporting that it is pretty solid.
Yeah.
So if you do have that, just be cautious to make sure that you can secure it.
Yeah, I think that you're right.
Very
That's
well.
the biggest.
And your sizing. Make sure your sizing's appropriate and that you are securing the hell out of it.
And if you put something in and that is not what you expected based on your measurements and things like that, that can happen. Sometimes people have their airways are deceiving.
Sometimes they're very long.
Yes, based not on their exterior. So it's okay to take that out and put a different size in.
Yeah, resize.
Don't leave one in. That's not appropriate.
Yeah, don't do like a good enough situation.
Yeah.
And lastly, but certainly not least in tools, suction. A salad.
We love some suction, even though we accidentally turn on the vacuum instead.
All the
For
time.
the truck. Or the vent, whatever. Salad, we should probably all know salad. I would
For
think
sure.
by now it's becoming so standard.
For sure. So we're all pretty familiar with suction, but more popular is the salad technique, which is suction-assisted laryngoscopy and airway decontamination. And a lot of times what that looks like is like a decanto or something that you just kind of stick in there.
Yeah, we like that one. Pretty much do that every time now.
Right, and suction is like that surprise, like fairy godparent that just like comes scooping in, and you're like, oh, I'm so glad you're here.
Yeah, and that's another one. Like if you don't do the same every time, you're gonna forget things like getting your suction ready. Remember that GI bleed that we had?
Yes.
Parked that decanto right in the esophagus, and it was literally like I was just like, thank God.
It was beautiful. Was that the same one where the facility's suction device was like essentially gas powered?
There was a cork in it. Why was there a piece of cork in it?
I have no idea. It was we went to a facility for a cardiac arrest, respiratory failure, turned cardiac arrest, secondary to GI bleed. And we ended up with a working suction device that Soph got to park in the airway, and it went super well. However, the facility,
what dreams are made of.
the facility offered up a suction device that was on a rolling cart that I swear you probably could have turned it on like a chainsaw, like a full-on like crank motor.
It was like
a weed whacker.
It was just so crazy.
It was so aggressive that it was trying to vibrate off of the cart.
Literally. And the cart was made of PVC pipes.
Yes, 100%. Actually, PVC pipes.
Yes.
And it was trying to vibrate off the cart and run away.
It was a fantastic situation for the comedic relief portion. We absolutely crushed it.
Yeah,
it was a great call.
It went really smoothly. But there were the bouncing suction on the PVC pipe cart.
With the random cork inside of it.
With the cork inside of it in the corner.
Ping-ponging around.
Yeah, just like beating up the corner of the wall.
It was kind of like a paramedic school scenario, just because there was a bunch of noise, there was a bunch of random people saying things that were irrelevant, doing things that were irrelevant, and then we were just on it. We were
It was pretty good.
We were zoned in. Well, that was fun.
Yeah, I did enjoy that. So, as far as your airways go, it is not about being perfect. It's about being ready, staying humble, and never underestimating the basics. This has been Life in Sirens, produced by 3 nerds trying to bring you content that you might actually care about.